Okay, there was not a blueprint, so let me go over briefly. I don't know if she even had on some of the other ones, she still had the old book, but anyway, so for prenatal journey, this was divided into 4 areas. So prenatal journey, for that section, there's 19 questions. There's 7 from chapter 13, none from 14, 2 from 15. So prenatal journey, 19 all told. So chapter 13 is 7. Chapter 14, there are none. And in fact, we won't cover that in class. I will review that on Blackboard. Chapter 15, there are 2 questions. Chapter 24, there are 3. Chapter 25, there are 6. Chapter 26, there is 1. And chapter 31, there is 0. Then the birth experience, there's a total of 12. And chapter 16 then is 3. Chapter 17 is 3. Chapter 18 is 2. Chapter 19 is 1. Chapter 27 is 3. Then care of the family, there are a total of 7 questions. And chapter 20 is 3. And chapter 28 is 4. And then it sort of says care of the new family continued, but in reality this is about the high-risk newborn. So there's 11 questions there, and chapter 21 is 5, chapter 22 is 3, or 2. Let's see, is that 2 or 3? Let's see, 7, 8. 2, that's 2. Chapter 29 is 1, and chapter 30 is 3. And I'll see if I can get that on Blackboard, but I didn't have time. I didn't notice that until late last night.
Or the high risk ones again?
High risk, the newborn ones?
Yep.
Chapter 21 is 5, chapter 22 is 2, chapter 29 is 1, and chapter 30 is 3. Okay, so we're going to start out with chapter 13, looking at high risk perinatal, which, and then high risk newborn, which this learning plan is all about. So first we're going to look at what happens in the prenatal period. Obviously there are many changes that are occurring in the woman's body during pregnancy and in response to pregnancy. And of course the reproductive system has the most significant changes, and particularly in the uterus. The uterus starts out sort of pear-shaped. It's very small, weighs only about 1/4 ounce, but at full term it can go up to about 2.4 to 2.6 pounds. It has the ability to stretch significantly. It grows by hyperplasia and also by hypertrophy, so it extends. So when pregnancy occurs, growth in the uterus occurs according to a predictable pattern, just like when we said with shock. Shock occurs according to a predictable pattern, so does pregnancy. So some of the things that you should remember are where should the uterus be, the fundal height at certain periods of time. Now, at 20 weeks of gestation, the uterus should be at about the level of the umbilicus. And it then, by 36 weeks, reaches up to the xiphoid process, and that's why it becomes so much more difficult for a woman to breathe. The height or the fundus, the height of the fundus helps to determine the actual estimated date of delivery, or sometimes they also call it EDC, estimated date of confinement, or EDB, estimated date of birth. All kind of means the same thing. So it helps estimate the date of birth. Also, during that time, the cervical canal fills with mucus, And by doing so, it helps to protect the baby from bacteria that can move up the reproductive tract. So here's uterine growth during pregnancy. You can see that at about 20 weeks, the fundus should be at the umbilicus. After lightening is when the baby's head descends into the pelvic cavity. And basically at that point, it takes pressure off the diaphragm so mom can breathe a little bit easier. Cervical changes that occur during this period, again, we said there's that mucus plug that forms in the cervical canal to protect the infant against bacteria. And in fact, bloody show is one of the, oftentimes occurs when labor is about to start. And what that bloody show is expelling that mucus plug, and then there's a little bit of blood because of the roughness of that as it comes out. So bloody show is sometimes something that we see when labor begins. There are also hormones that are creating changes, such as estrogen. Estrogen causes blood congestion and hyperemia within the cervix, and so it causes what is called Chadwick's sign. And that's from blood congestion. It's sort of a bluish purple color that extends not only from the cervix but to the lower end of the vagina, and sometimes you can see it on the labia as well. And it is one of the earliest signs of pregnancy that we see. So when a physician or a midwife is doing an exam, she will see Chadwick's sign fairly early in the pregnancy. Another sign in the cervix that we see is Goodell's sign, and that's when the cervix actually starts to soften. Then we also see changes in the breasts. Obviously, they become larger. Estrogen does increase the growth of mammary tissue, and it also stimulates growth within the breast tissues and within the lobules of the breast. We start to see colostrum, that very thin secretion from the nipples, at around 12 to 16 weeks of pregnancy. That's fairly common. It's sort of a yellowish fluid. Also on the breasts, we have sebaceous glands that are also called the tubercles of Montgomery, and they actually secrete a little bit of fluid that actually lubricates the nipples and prepares the nipples for mom to breastfeed when delivery actually occurs. So here we can see that the breasts do enlarge. You also see stria gravidarum, which are basically stretch marks. The areola gets darker and enlarges. There's increased vascularity because of the estrogen, so you have hyperemia. And usually the nipples stand more erect as well. So lots of changes in the reproductive system. In the cardiovascular system, because there's expanded blood volume to support not only mom but also baby, we can see some changes that occur. Usually blood pressure does not increase. If it does, that's a concern. Arterial blood pressure, however, can be affected by position during pregnancy. And that's when you can develop supine hypotensive syndrome. So if a woman's laying flat, what happens is her enlarging uterus will actually put pressure on her vena cava and also on the aorta. And so she can develop signs and symptoms of lightheadedness, dizziness, maybe even nausea. She may even become a little agitated. And the thing to do in that case is to get her onto her side. Generally, we'll turn them to the left side. but at least get them sidelined. It takes the pressure off the vena cava and the aorta. In addition, plasma volume does result in what we call physiologic anemia. It's not true anemia, but it's because of the dilution of the RBCs. And so typically what we'll see is women who have never had a systolic murmur, you may now hear a systolic murmur. Because of this anemia, they may require iron supplements, and almost always women are placed on folic acid and iron. Also, you're going to see some increased leukocytosis because of the increased volume. And they're also at risk for blood clots because there is a hypercoagulable state for the woman. So it is important, if mom is sitting or standing for long periods of time, that she be aware of that and change positions and exercise and move herself out of that increased risk for DVT. So here's a picture of what can cause supine hypotensive syndrome. Here, the pressure on the aorta and the vena cava actually causes that lightheadedness, dizziness. So get them on the side. Here it's showing right lateral, which is fine. It's either just get them side lying, and it takes the pressure off of that. So again, be alert to mom who is laying flat, then starts to complain of lightheaded, dizziness, may even become agitated, as we said. With regard to the respiratory system, generally moms hyperventilate, that's normal, and the airway actually develops less resistance, and therefore oxygen needs are usually met by the pregnant woman. Pregnancy increases oxygen consumption by about 20%. And of course, the need for that is to support the growing baby and to get adequate oxygen to the uterus and to the placenta. And then obviously the rest of the oxygen has to prepare mom's body in order to deal with the pregnancy. So estrogen increases blood supply, and as capillaries engorge and get larger, the upper respiratory system is affected because there's more edema and hyperemia, and that causes congestion even in the respiratory system. So it's not unusual for mom to have increased congestion, nasal congestion, and even nosebleeds because there's more blood volume there. There's increased pressure there. We commonly see nasal congestion and nosebleeds in women who are pregnant. Other physical changes, the chest circumference increases, the ribs actually increase, and so mom can actually get more oxygen in there. There are some significant changes in the skin where mom becomes hyperpigmented. Melasma, also known as the mask of pregnancy. Moms can sometimes develop a darkened pigmentation on their face. Stria gravidarum, or stretch marks, common on the breast but also on the belly. Linea nigra is a darker pigmentation that they can find from the umbilicus down the middle of the belly. Very common. Also, muscle strain and backaches, particularly in the last trimester, are fairly common. And the reason for that is as the uterus enlarges, mom usually leans backward and she kind of puts herself into a lordosis position, and that also strains the back. The other thing is many moms, as they get larger, are not happy with their appearance and their body image, so that's something to think about as well. And this is a picture of that Linnaea nigra that you see on the belly, that hyperpigmentation. And you can see she is having some stretch. I would say this lady has probably been pregnant before. The kidneys and ureters also change. There is increased GFR rate. And what happens there is that she can actually spill some glucose and protein into the urine. Because as the uterus grows, it puts more pressure on the ureters and the bladder, so it increases the frequency of urination. It also puts them at increased risk for urinary tract infections because remember, glucose and does increase the environment for growth of bacteria. And mild proteinuria is common. If it goes beyond that, that becomes a concern, and moms could actually be developing preeclampsia. Other placental or other changes occur because of hormones. HCG, human chorionic gonadotropin, which is used to verify and validate pregnancy, and also estrogen levels do play a role in nausea for moms early in pregnancy. Also, increased progesterone actually releases the smooth muscle, and that then makes it more difficult for mom to empty. And also, that's both from a urinary standpoint and also from a GI standpoint. So it increases her risk for infection because of stasis of urine, and then also for constipation. Also, progesterone has that dual role of preparing the lining of the uterus and to maintain the pregnancy. It also then prevents contractions. We have Braxton Hicks, which are fairly common in pregnancy. Remember, those are irregular contractions that don't actually dilate the cervix or result in effacement. And also, progesterone helps to prepare the breasts for lactation. So we said there are changes in the uterus. At about 6 to 8 weeks after a woman's last menses, the uterus does soften, the lower end of the uterus. We call that Hagar's sign. Ballottement can occur. What that is when you tap on the uterus, the fetus will actually go up in the uterus and then sort of come back down. So it's like it floats up and then comes back down. That's what we call ballottement. Those Braxton Hicks, as I said, irregular contractions that are usually occur throughout pregnancy, but they don't do anything. And then palpation of the fetal outline usually can be felt in the second half of pregnancy. However, in women who are quite obese, it is difficult sometimes to feel those outlines. This is Hagar's sign. Remember the softening of the lower portion of the uterus. And that is some of the uterine changes that occur. This is ballottement. Again, if you tap on the cervix, the baby actually rises and then falls back down, ballottement. Then there are 3 classifications of pregnancy, and each are the only positive ones that for sure signify pregnancy are the positive ones, but we have presumptive signs where we presume pregnancy is occurring. It's subjective and it's much less reliable than positive, but amenorrhea, the absence of menses. Nausea and vomiting does occur in about 60 to 80% of women. Fatigue, particularly in the first trimester, is typical. And this is fatigue that they've not had before. Urinary frequency, particularly in the first trimester, and it does indicate fluid volume changes. Remember that blood volume increases in the third semester trimester when women are increasing their urination. It's usually because of pressure on the bladder from the heaviness of the uterus. Breast and skin changes. The breasts, because they're enlarging in size, may feel tender. They may have tingling sensations. They may feel quite full. We see those pigment changes on the face and, with stretch marks, and then also the linea nigra. Vaginal and cervical color changes, again, one of the earliest signs of pregnancy is that Chadwick's, that bluish purple coloration of the cervix that we see early in pregnancy. And then, however, other things could cause that, not the least of which, and I'm thinking of Housewives of New Jersey. One of the women was jumping or getting out of her window, and she fell with her fell onto her vagina, and that created bruise to her area, and so other things can cause that as well. Fetal movement usually is felt in the second trimester. We call that quickening. And it usually occurs between 16 and 20 weeks. Then we also have probable signs. These are more objective signs that an examiner could actually document. So abdominal enlargement, usually when women come in for their initial treatments, we do take some measurements, and so if we see that abdomen enlarging, cervical softening, again, that Goodell sign. Uterine changes, if we see the fundal height rising, and then pregnancy tests where we're actually detecting human chorionic gonadotropin. Then positive signs. These positive signs are caused only by pregnancy, so that's why we call them positive. If we can auscultate fetal heart sounds, if we can feel fetal movements, and then also if we can visualize the fetus on an ultrasound, those are positive signs. When women come in, women before they get pregnant should actually have a preconception visit. In other words, to make sure that they are healthy and can go through a pregnancy in a confident manner. So in their initial antepartum visit, you want to always get a complete history. That includes not only obstetric history, but menstrual history, estimated date of confinement, any gynecologic history, have they had surgery, do they use contraceptives, what's their medical history, what kind of medications are they on, what family history do they have. So for example, my mother had 6 miscarriages, and so that always was an important bit of history in mine and my sister's development. Physical exams, obviously you need to go through those physical exams, and that includes tests as well and labs. Potential risks, you want to assess, again, any obstetric history, any medical conditions, how could they affect the pregnancy if they have cardiovascular history, for example. Demographics, what is their age? We know that older women have an increased tendency for abnormal pregnancies. What is their social and personal history? Are they a single parent? Do they have support? Baseline data, obviously, vital signs, labs, and then to discuss the plan of care. How do they plan to have the baby? What is their plan? Basically, in subsequent, usually women will go back to their physician every 4 weeks for the first 28 weeks. Then from weeks 29 to 36, they go every 2 weeks, and then after 36 weeks, so at 37 weeks till birth, they usually are going every 1 week. Now, the average weight for pregnancy gain should be about 25 to 35 pounds if a mom is at normal pre-pregnancy weight. Obviously, this is an individual thing. Urinalysis should be done at every visit. Obviously, they're checking for protein, for glucose. They're also looking for ketones. And they may do nitrate dipstick to check for bacteria because pregnant moms are at increased risk. Glucose screening usually is done at 24 to 28 weeks. Remember, there is something called gestational diabetes that affects women who are pregnant. And usually at about 24 to 28 weeks, they will do a glucose challenge test. And then if that's positive, they may do a glucose tolerance test to check actually for gestational diabetes. Isoimmunization, that becomes an issue if we have an Rh negative mom and an Rh positive dad. We therefore do not know what the baby will be, so at 28 weeks gestation, mom should receive the Rh immunoglobulin, because we don't know what the baby will be. Fundal height, again, helps us to evaluate fetal growth, and it also helps us to confirm gestational age. And then fetal evaluation, we can do that using Leopold's maneuvers, trying to determine where baby is and how baby is positioned, listening to fetal heart rate, also doing kick counts or having mom do kick counts, and fetal movement, checking for fetal activity. And then also we should be instructing moms about the signs of labor and what needs to be watched. When mom goes in for prenatal care, they will measure her uterus again, and that usually is from the top of the symphysis pubis to the top of the fundus, or that upper layer of the uterus. During pregnancy, there are a number of concerns and complaints that moms have. Nausea and vomiting, as we said, about 60 to 80% of moms do experience that. Some experience it rather severely. With my first pregnancy, I lost 16 pounds in the first 3 months. I was so sick. To this day, I can hardly say the word sukiyaki because I had that during my pregnancy, and it just kind of gives me the shivers. I was throwing up so bad. But as pregnancy progresses and as the uterus enlarges, usually what happens is moms will experience shortness of breath. Stair climbing may become more difficult. They may develop ankle edema, which is fairly common. And usually that occurs in the later afternoons, particularly for moms who find that they've been on their feet a lot. Heartburn is a common complaint because as the uterus rises, it does put pressure. Backaches are fairly common, and especially if mom is in prolonged standing situations for long periods of time. And actually, a primary focus at this point in time for nurses is actually to review with mom the principles of body mechanics and of posture. Very important because body mechanics and posture can alleviate back pain and other complaints that mom has during pregnancy. Round ligament pain usually is manifested in sort of a sharp stitch in their side. Urinary frequency we know about, varicosities because of the increased pressure. And so a lot of women are encouraged to wear TED stockings. Those should be placed on their legs before they get out of bed. Remember, they're already at an increased risk for DVT because of an increased hypercoagulable state. Hemorrhoids because of increased pressure. Constipation and also leg cramps can all be complaints of discomfort. So again, body mechanics and posture, very important teaching element in this early stage. Obviously, an improper position, a more proper position. Throwing her shoulders back, and that will help to alleviate back pain as well. Same thing with body mechanics. If you're going to lift, be as close to the area or the item you're going to lift. You don't want to bend with your back, but bend with your knees and then move to a standing position. So squatting places less strain on the back. So again, teach mom about some of those things. Other exercises that will help to relax the back include relaxing the shoulder, sitting in a tailored position, doing a pelvic tilt or pelvic rocking. All of those exercises can help alleviate pain that is caused by loosening muscles actually because of the hormones of pregnancy. During the third trimester, pillows that support both the belly and the back actually will help to provide more comfortable positioning in that third trimester. During those periods, basically interventions that we would want to participate with mom is, discussing appropriate way of perineal care, cleaning. She should avoid douching. Breast care, preparing the nipples for lactation. The importance of wearing loose clothing and not using tight clothing that could impede oxygenation to the infant, as well as could cause increased problems with DVTs. Exercise is still important during pregnancy, certainly not to overdo. Getting adequate sleep and rest. Adequate nutrition is very important. To remember that mom is now supplying nutrients to not only herself but also the infant. With regard to employment, women can work all the way through their pregnancy rather safely, but one of the things you should discuss with her is whether or not her job puts her at increased risk for exposure to teratogens, like, is she near chemical exposures or drugs that potentially could cause abnormalities in the fetus. With regard to travel, travel is fairly safe throughout pregnancy, except in the last few weeks. Certainly many women travel even in those periods, but you kind of want to talk about it on an individual basis. The other thing is, depending on where she travels, for example, if I was pregnant, I probably would not want to go to a high Zika environment. If I'm going to a country where perhaps immunizations are required, I would want to make sure that the immunization that I'm getting is safe. Live vaccines should be avoided in pregnancy. Vaccines that are dead, those things would be okay for moms to get. Lifestyle changes, obviously staying away from alcohol and drugs, being careful about over-the-counter medications. Complementary and alternative treatments should be discussed with the physician. No smoking. Smoking does increase the risk for premature labor, preeclampsia, a variety of things. So there are a number of things you want to discuss with mom during pregnancy. Now, there are some danger signs that we need to be alert to, and so you want to discuss these with mom as well. Signs of possible complications, vaginal bleeding, whether or not it's uncomfortable, rupture of membranes or seepage of fluid, swelling of the fingers or development of the angioedema. Remember, that's swelling of the periorbital area, the lips, the mouth, etc. A continuous pounding headache is not normal. Visual disturbances, not normal. Those things you would want to alert the physician to. And also persistent abdominal pain, and doesn't even have to be severe. Abdominal pain could indicate premature labor. It could indicate placental abruption as we move through the pregnancy. So abdominal pain would be a concern as well. And as I said, it doesn't even have to be severe. Chills and fever could indicate that mom has an infection, painful urination, persistent vomiting. They could develop hyperemesis gravidarum. Changes in frequency or strength of the fetal movements. In other words, if you have at one point felt significant movement and then that diminishes. And then they should also be aware of signs of preterm labor, uterine contractions, cramping, constant or irregular low back pain, and also pelvic pressure. And again, remember that abdominal pain can indicate preterm labor as well. So when mom becomes pregnant, she does have some psychological responses to pregnancy as well. In the first trimester, she does feel uncertain. Basically, at that point, the baby is not real. Ambivalence, there are conflicting feelings. Does she want to be pregnant now? Does she not want to be pregnant? Is this going to fit into her lifestyle? In the first trimester, mom is still focusing on herself. In the second trimester, when some of the physical evidence of pregnancy, such as quickening and lightening occurs, and mom sees the baby or the fetus on ultrasound, there is early bonding that occurs. And there the fetus starts to become the focus, but mom is still sort of narcissistic and introverted. She still has an undue occupation about herself, and she concentrates on her body and on herself. Her body image is very subjective. She may enjoy pregnancy, she may not enjoy her appearance. And part of that is how she responds and how her significant others and family are supporting that self-image. And then also there are changes in sexuality. She may not have a desire for sex. It might be simply related to fatigue that she has not had before. And then there are other concerns that may arise as well. So, let's see, pregnant woman being discharged after placement of a cerclage. A cerclage is when the cervix is insufficient to maintain the pregnancy. So what they do is they put a suture through the bottom of the cervix and sort of tighten it up. It's like a purse string suture. And that's placed in order to try and maintain the pregnancy. So what should discharge teaching emphasize here? Say again?
Well, it's saying probably like no straining.
Yeah, the thing of it is though, because she now is closed, and she's not gonna be able to, have the baby. The most important thing is she should be aware of what the signs and symptoms of preterm labor are. Because if she is going into preterm labor, that baby is going to not get adequate fetal oxygenation. So presence of any cramping, low back pain, because it could indicate preterm labor, those kinds of signs and symptoms should be reported. Okay, so here it looks like mom and dad are actually feeling the baby move and confirming. That helps for them to confirm the baby as a separate entity. And this usually occurs again in that second trimester at around 16 to 20 weeks. In the third trimester then, mom at around 7 months starts to become vulnerable, fears that her baby won't be born appropriately. She may experience nightmares at this point in time. She has increasing dependence on her spouse or other family members, finds it sometimes very hard to focus, and is very active in preparing for birth, maybe involved in childbirth education classes, etc. So in the third trimester, mom does feel a little bit more vulnerable. Here mom is cradling that baby. Basically that simply signifies that she's trying to protect the baby. There are tasks that must be completed by the parent. For mom, obviously, she wants to make sure that her delivery will be safe. So she chooses to go either with a physician or a nurse practitioner. She addresses her diet. She may, she becomes compliant with vitamins, etc. Adequate rest. She goes into her physician for her appointments. She secures acceptance, and she does that by actually becoming closer, usually with her mom or a significant mother figure. And she starts to learn to give more of herself. Remember that in the early stages she's narcissistic and introverted. Now she's expanding outward. And she's starting to develop an attachment to her infant. And what you'll see then are affectionate ties or motions that are directed toward the baby. From a father's standpoint, because they don't have these bodily changes, it is more difficult to accept the reality of the pregnancy and that a baby will be coming. It's like they become, where they are helping their spouse, but they're not a parent. So they are like a helper, but not a parent. And so for guys, it becomes a little bit more difficult. We call creating a role of a involved father as couvade, C-O-U-V-A-D-E. And that is when dads actually will show behaviors that might be similar to mom. Dad might have a little nausea. Dad might have feel like he has to go to the bathroom more frequently. He's trying to get into that reality of, the baby coming. Reality boosters, such as hearing. Here he's got the fetoscope. Actually hearing the fetal heart rate is helpful in making it more real for the dad then. Other family members may have to adapt to the pregnancy as well. Grandparents oftentimes are very involved. One of the things you have to be careful about is that they not be too involved. Also, they may have some horror stories, as may other members of the family. Obviously, their experiences are important, but you have to make sure that you're being realistic, and that's why nurses teaching about pregnancy is so important. Age may be a concern, or if this is a first-time grandchild, obviously there's going to be more excitement. If moms or grandparents have 20 other grandchildren, you know, the experience of having a 21st may not be the same as it was for the first. And sometimes parents, you know, are offended by that as well. And so you need to be aware of that. With regard to siblings, toddlers in particular, oftentimes, you know, they're the babies of the family. A lot of times you have to change their sleeping arrangements as a new baby comes. Make sure that's done early enough, several weeks before the baby comes. Obviously, you're probably going to experience some jealousy. When the baby first comes, they may, you know, even be actually angry. They may not want to touch the baby at all. I mean, there are a variety of signs and symptoms that you might see. Resentment at not being able to be in mom's arms all the time. You know, where that toddler was always carried around, now she's carrying mom, and the toddler has to walk and hold on to mom's hand. Obviously, he feels displaced, he or she feels displaced. Older children oftentimes have a lot of questions, and so make sure that you provide them with answers as honestly as possible. Sometimes younger children or older children are included in classes that are helpful, and they can even go to the hospital, and that's a good experience. Adolescents sometimes, especially with if they're older, sometimes are embarrassed by the fact that their moms might be pregnant, because it's admitting that mom and dad's participate in sex. And you know, if that's a issue for them now, that it can be an embarrassment for them at that point in time. Other factors that can influence adaptation include age. You know, if you have a teen pregnancy, if you have an older woman have increased fears of abnormalities. Down syndrome, well-known abnormality that occurs to older women. Multiparity, if you already have children, you know, you're going to have increased fatigue. Are you going to have time for all of the kids? Obviously, there's going to be a change in the relationship with these kids. Do you have social support? Do you have a partner? Do you have family? If you're living in California and you have no family there to assist you through other than your spouse, that can be increased stress for sure. Absence of partners, obviously. Socioeconomic status, if you don't have funding to pay for diapers, to pay for childcare, etc., all of those factors can play a role in adaptation to pregnancy. Obviously, we were talking about siblings. Mom tries to spend time with their children, tries to, you know, show them affection and give them a sense of security. But regardless of that, most kids do go through periods of resentment and or jealousy at some point in time. Also, there are cultural differences, health beliefs. Asian families, my daughter-in-law is from Laos, and the belief there is that mom usually is less active in the first days post-delivery, and so family cares for the baby. And so, you know, understanding those cultural things. Health maintenance during pregnancy, you know, was prenatal care part of that? this concept of fate, preventing illness. We talked about immunizations. We said that moms, and we're seeing the repercussions of that, where moms are not getting infants vaccinated. Remember that inactivated vaccines are safe during pregnancy, so things like tetanus, like hepatitis A and B, like an influenza shot, those are safe during pregnancy. Unsafe would be live virus vaccines, so MMRs, varicella, smallpox, those would be contraindicated because those can cause teratogenic effects on the fetus, and we can see some abnormalities. Also, I just wanted to briefly talk about female genital cutting because we are starting to see more immigrants coming to our country that have experienced this. In Africa, female cutting, genital cutting was actually a precursor to marriage, and it increases the risk for a number of problems for these women. There is increased risk for obstructed labor because they could have scarring. They may have an increased risk for laceration because they have thinning of their genitalia. They're at increased risk for hemorrhage, and they're also at increased risk for infection. So genital cutting does put them at risk for a number of things. Now, mom also needs to choose whether or not she's going to deliver in the hospital, at home, in a birth center. Obviously, the birth center is less institutionalized than the hospital would be. The determining factor for setting is actually sometimes insurance. Insurance may not cover, and so that may actually play a role in your choice of setting. Choosing to have a midwife or a physician. A lot of times women will have their husbands or a significant other in with them during the birth. We also have what are called doulas. They are trained labor support persons, usually hired by the mom or employed by the mom, and they provide both physical and emotional support to the mom during the birth and delivery. Also, pregnant moms may ask significant others such as sisters, friends, moms even, to attend classes or to support them through the actual labor process. Education classes are very important. Preconception and early pregnancy classes emphasize early and regular prenatal care and ways that you can decrease negative pregnancy outcomes. Early pregnancy does focus on the first 2 trimesters, but they generally review exercise, childbirth, preparation, anticipated or unanticipated C-section, so they usually do cover that. Breastfeeding, parenting, they include fathers. There also can be some postpartum classes, and those usually start in the hospital. So nurses are very important in teaching some of these classes. They're very important in helping to teach the support persons as well as to how to support the pregnant woman through the pregnancy. Okay, I'm going to skip through nutrition for childbearing at this point. There aren't any questions on that, but I am going to, I'll cover that on a review. It is something that you definitely should be aware of for boards, especially you should be aware of nutritional requirements during pregnancy, and then also factors that can influence nutrition, such as smoking, drugs. Something that's unique to, or not always unique to pregnancy, but pica, eating things that are non-food or non-food components that can actually be detrimental to the infant. And then it also covers areas of special concern during lactation, and those kinds of things are important as well. And as I said, I'll cover that in that. So what I want to go over now are prenatal diagnostic tests. And there are a number of tests that are done in the prenatal setting. Ultrasound does give us real-time scanning of movement within the uterus. Usually it's three-dimensional. Doppler ultrasound allows us to see blood flow through the umbilical artery. It's helpful in assessing hypertension as well as fetal growth restriction. We want to make sure that the baby's growing at an appropriate progression. Alpha fetoprotein, or AFP, that's the main protein in fetal plasma, and if it's been associated with fetal anomalies, if the level is abnormal. And what we see is that AFP will accumulate in mom's blood. It also can accumulate in the amniotic fluid. Other marker screening, we can look in the human chorionic gonadotropin, also in estriol, for some markers that are unique to anomalies such as trisomy 18 and 21, which are genetic abnormalities. We can do chorionic villus sampling, which helps us to diagnose chromosomal abnormalities in fetuses, DNA changes. And then amniocentesis usually involves withdrawal of amniotic fluid through the abdomen, oftentimes done in the second and third trimesters. Other tests can include percutaneous umbilical blood sampling, where you aspirate some fetal blood from the umbilical cord. We do that to check RH with infections and infections. Also, we can do antepartum fetal surveillance. We can do non-stress tests. There we check to see if there's an increase in fetal heart rate when there's movement of the fetus. That is normal, and that would indicate that there's adequate fetal oxygenation. Also, there are fibroacoustic or hearing stimulation tests. Is there fetal movement with a loud noise, for example? Contraction stress tests usually are done with oxytocin, and they're challenged to see if contraction occurs. Biophysical profile, and we'll talk a little bit more about those. Modified, we'll talk more about those as well. And then mom's assessment of fetal movement are also some tests that we can look at as well. So ultrasounds are used to check not only fetal but placental conditions. We can check the placement of the pregnancy. Remember, we have something called placenta previa, where the placenta attaches low in the uterus. A complete coverage of the os is certainly an increased risk for hemorrhage and bleeding. Multifetal gestation, we want to know if mom is having more than one fetus. Gestational age, ultrasound will confirm gestational age. Also, viability, is the baby still living? Ultrasound is sometimes used along with other testing such as amniocentesis, as well as with Doppler ultrasound, again, does check flow through the umbilical cord. When a mom has, when they are checking an ultrasound for fetal condition, sometimes it's suggested to drink juice. And research doesn't prove that, but it's kind of a common practice. And the thought behind that is that it will increase the glucose, and that stimulates fetal movement. So sometimes, they may have you do that. Here's a two-dimensional ultrasound. It shows the fetal profile. Here you can see the arm, the hand, the fingers, etc. This is a three-dimensional ultrasound. It shows the baby in the third semester because you can see full development of the face, nose, mouth, etc. And ultrasounds vary. Sometimes they're done around 4 months, and sometimes they're done more frequently. Sometimes they're not done at all, but usually women will have at least one ultrasound. Here the sonographer basically is explaining what is happening during this, and she's moving over the belly, moving the transducer over the belly to get the image. Color ultrasound can also be done. Again, here what you see in the red, those are actually showing umbilical veins and umbilical arteries. There are 2 umbilical arteries and 1 umbilical vein. So if they're checking for adequate flow and oxygenation. Then we talked about AFP screening. Again, it can be done on mom's blood or on the amniotic fluid. It can look for defects as well as chromosomal abnormalities. In addition to AFP, they can look for other markers that might be indicative of other chromosomal problems. The chorionic villus sampling, usually it's not performed before 10 weeks. Again, it does check for chromosomal defects. It also can check for metabolic abnormalities, which might include some changes in normal metabolism that is occurring in the pregnancy. Trans-cervical chorionic sampling, basically what happens is here your ultrasound transducer is being used, and what happens is tissue is aspirated to identify genetic defects in the fetus. And so that is another test that can be done. Second trimester, we said that amniocentesis is often done in second and third trimester. Reasons we might want to do a second trimester amniocentesis: if mom is 35 or older, if there has already been chromosomal abnormality, if mom has a Down syndrome baby, the likelihood of having a second is much greater. Sex determination, especially if there's X-linked disorders. If, again, infant has already been born with a chromosomal abnormality. Also, if there is neural tube defect or body wall defects. Pregnancies after multiple abortions, spontaneous abortions, you want to get as much information early on in the pregnancy as possible so you can help to maintain that pregnancy. If there's elevated AFP that you can't explain, and then also if mom has had sensitization to RH. So in amniocentesis, a needle is inserted through the abdomen into, and basically what they do is aspirate fluid from the amniotic sac, and then they test that fluid for chromosomal markers or abnormalities or other problems. They also can determine fetal lung maturity with an amniocentesis. Remember, if mom anticipates preterm labor, baby is at risk because the lungs are not adequately mature. And so a lot of times what will be given, mom will be given corticosteroids to enhance the development of lung maturity. Percutaneous umbilical cord sampling is also done. Here you aspirate fetal blood, and again, it detects blood disorders. It can also detect acid-base imbalance, infection, and other genetic diseases. And so what we have here is that percutaneous umbilical blood cord sampling. A needle is inserted through mom's abdomen into the umbilical cord vessel. It can be either into the vein or the artery, and then you just withdraw that blood sample. Then, as we talked about fetal surveillance, so a non-stress test looks at fetal heart accelerations with or without fetal movement. And nurses can do NSTs. They can conduct the initial assessment and even begin interventions for non-reassuring results, but they need to be trained and have special education in order to do that. Also, when we're looking for reactivity, if baby moves with, is reactive with, and we see accelerations, that's a reassuring sign. And that usually means there's adequate fetal oxygenation. And sometimes we won't see that until around 32 weeks. In order to prepare a patient for an NST, you want to make sure that mom is seated in a reclined position, comfortably in either a reclining chair, or if she is in bed, put them in a semi-Fowler's position. Also, if they're on a stretcher, put the head of the bed up into a semi-Fowler's position. The reason we do that is because it optimizes the oxygenation to the fetus, and it encourages uterine perfusion, and it prevents supine hypotension. Remember, if mom is laying back, she may have pressure down onto her vena cava. Basically then for the NST, you put some conduction gel, and then you apply 2 belts on mom's abdomen. One is a Doppler transducer. It detects the fetal heart rate. The other one is a dynamometer, and it detects fetal movement. So one checks heart rate, one checks movement. Or it can also check for uterine contraction. So here is a nurse doing NST, which is a non-invasive stress test. It again measures heart rate and to acceleration in response to fetal movements. And it looks like mom is just providing some reassurance here, and she's pointing to the fetal heart rate that is detected by that monitor then, and you can see she has 2 belts on. So one's for the transducer, checking fetal heart rate, the other one to check movement. And these are just what the strips look like. This first one is a reactive non-stress test, which again is reassuring. This one is a non-reactive NST. There is acceleration that is absent after fetal movement, and you want to see activity and movement. So, in the CST then, a contraction stress test, we use that to see how the fetal heart rate responds to uterine contractions. As we said, we oftentimes will use oxytocin as a challenge, but it's contraindicated if we shouldn't contract the uterus, if there's an increased risk for preterm labor or something of that nature. And this is just, again, the strip indicating that, doing the CST. So biophysical profile, basically what we're looking at is 5 parameters. We're looking at the NST, the fetal breathing, gross fetal movements, fetal tone, and the amniotic fluid volume. And that is a way to quantify the amount of amniotic fluid that we see on the ultrasound. And this just shows that the effects of gradual hypoxemia and what we see as worsening fetal acidosis. So one of the first signs as oxygen is diminished and acidosis occurs is late decelerations. Then those accelerations disappear. Then fetal breathing movement stops. Then all fetal movement stops. Then we don't have fetal tone. So it is progressive. Now another, when we are asking mom's subjective, she checks movements of the fetus, and we call those kick counts. There's a couple of ways that mom can count. She can do at least 10 fetal movements within 12 hours, but the more common one is this, counting 2 to 3 times a day and identifying whether the fetus has at least 3 movements in 60 minutes. So those are kick counts, and mom participating in that, it helps her again to accept that she is indeed pregnant. Now, when we look at diagnostic testing, we want to make sure that we are aware of what mom's current history is, what the health problems, any obstetric problems, whether or not mom uses alcohol, substances, and also if she is a smoker. We want to make sure that moms understand why we are doing tests, so we're explaining, and then why we are doing these surveillance regimens, and then when it would require additional testing. And also, we should be aware of how mom is responding to a test. Obviously, if we don't explain, that there's no movement, and we don't have a reason, that can be quite frightening to both mom and parent. So, biophysical profile includes information regarding all factors except which one? Breathing movements, yes. Gross fetal movements, yes. Amniotic fluid levels, yes. Not fetal length and gestational age. That isn't part of the biophysical. Okay, let's take a break and then we'll come back. Water. Actually, we'll probably get a little further. I don't. Quarter mile. This is kind of a nice review for those of us who have had babies. those of you who have not, it's a little bit more difficult. And of course, for the guys, it becomes a little bit more difficult. However, if they are fathers, when I look at this, I gotta tell you about what happened last night. I had the most gross traumatic experience last night. My husband and I went to Minneapolis, and I'm fairly certain, I shouldn't say this, but I'm fairly certain I had a cup of coffee from McDonald's, and it was in my car, and when we got home, I didn't want to leave it in the car, so I took it out and I brought it, put it on my counter. And then a lot of times what I'll do is I'll nuke it and then drink it,
You.
I didn't this time but I had it on, I was doing my schoolwork and I had it on there and I was gonna drink it, but I didn't. Go to the sink, pour it out. A mouse that big. I'm getting goosebumps just saying it. A mouse that big in my coffee
You're
cup.
kidding.
It had the
And I
lid on
drank
it?
half of that.
And it had the lid on it?
It had the lid
So
on it.
it came from McDonald's.
It had to have.
Shut
kidding me?
up.
It had
Oh my
to
God.
have.
McDonald's did you go to?
Well, it was Dallas City's.
How the hell did it get in the cup without
I
them
have
noticing?
no idea. How could somebody pour coffee?
They
And
probably
I am not
killed
kidding.
it
It
and
was
drowned
this
it.
big.
Did your husband put it in there?
Oh my God.
No.
Shut
I mean,
up.
he was down in the basement when I poured it in.
How did
I
it
like
get?
screamed.
Ah.
And it had to have been in there when the hot coffee was
my
poured in
God.
because
Are you kidding
I
me?
swear to God, there was no hair on that mouse.
Shut up.
It's, you
Oh.
drank the hair.
If I get sick in the next few weeks, you'll know what it is.
Oh my God. Get a mouse
I've never
vaccine.
seen that.
I have never either, and you know what, honest to
I would
God,
never
I
either.
don't even know where,
I would call.
it's like, but we
you.
stopped, we were at a couple of McDonald's, because we had all 5 grandchildren with us.
Oh my God.
And I was
That's a
like,
good story.
no, I couldn't even go, it took me 2 hours to go back into the kitchen. I told my husband, I said, you have to clean that sink, I can't even go in there, and then now every time, I will not
my
ever drink
God.
coffee again unless I watch them, look in the
would
cup
still
and.
You're gonna